So we're going to talk a little bit tonight about metabolic syndrome. And metabolic syndrome has a place in the scope of this course because of its direct impact on cardiovascular disease and its direct impact on the acquisition of diabetes mellitus. We recognize metabolic syndrome today as metabolic syndrome, but it has gone through a lot of scrutiny over the years, being called metabolic syndrome, syndrome X, or insulin-resistant syndrome. And the history of metabolic syndrome goes back as far as the 1950s. Okay? And in the 1950s, a Dr. Gene Vague recognized that there was a strong correlation between individuals that carried a lot of upper body weight or a lot of upper body obesity and the incidence of cardiovascular disease, diabetes, mellitus, and also gout. So he recognized that there was something going on between these three morbidities that seemed to be tied into the extreme presence of upper body fat. In 1997, 1997, Dr. Gerald Phillips developed the syndrome concept and the risk associated with cardiovascular disease. And what Dr. Phillips postulated was that rather than this syndrome being a set of silos of different diseases, that there was an interplay and an interrelationship between the presence of all of the morbidities that he was outlining there. So he called it a constellation of abnormalities. What Dr. Phillips also postulated was that we were in a time of social growth and economic wealth, with a lot of our soldiers coming back from wartime in the 40s and 50s. And so we had some growth and some wealth, and we had some extra income. And we also had access to a new pleasurable taste, and that was sugar. So, and we went through a period where drinking cola was a sign of affluence and wealth and unique to this nation. And then we came up with the development of plastic, and we had a new delivery system. So now we could put soda pressurized into plastic bottles, and you didn't have to go into a soda fountain anymore and get it mixed. And so we went through a period in the late 60s, early 70s, where we went through the cola wars. So we started to proliferate with Coca-Cola, Pepsi, and then we started to have Dr. Pepper, some of the local distributors, and then we went to non-cola, but sugary sweetened drinks like 7-Up and Mountain Dew. So there was a rise that was directly correlated with our incidence of drinking soda. So we had a new ingestion of sugar, and we saw that rise immediately after the early 70s. And so that's why this metabolic syndrome came about at just around 1997. And part of it was a collaboration of researchers associated with Dr. Phillips. So today, we call metabolic syndrome a constellation of risk factors for cardiovascular disease, for the incidence of stroke, and for the acquisition of diabetes mellitus, okay? And more specifically, type 2 diabetes. When we're looking to diagnose somebody with metabolic syndrome, we're going to take a look at 5 different abnormal conditions, and the presence of any 3 of these abnormal conditions leads to the classification of a person having metabolic syndrome. And having that classification also changes our treatment modalities. So we've begun to come up with treatment modalities and standardize these treatment modalities in order to maximize medical care for these people with metabolic syndrome. So number 1 medical condition appearance of centralized belly fat, right? So it's the centralized belly fat. The classification of that centralized belly fat is any waist measure over 40 inches around the abdominis, and more specifically around the belly button. Okay? And that is in males. For females, it's any waist measure over 35 inches in the same area. Okay? And those were guidelines set by the NCEP in the United States. The World Health Organization also adds two other classifications for the presence of upper body obesity. So they take a look at the waist to hip ratio. Waist to hip ratio 0.9 or greater in males and 0.85 or greater in females. But they also correlate that with a BMI over 30. So they take a look at both measures. And it's safe to say that when you have a BMI over 30, you're also going to have a waist measure that's above what we consider a normal waist to hip ratio. Okay. The second abnormality that we take a look at is the presence of hypertension. And any systolic blood pressure of 130 millimeters of mercury or greater, along with a diastolic measure over 85 is hypertension or pre-hypertension. And then they added to that classification already being medicated for pre-hypertension or hypertension. Okay? So, in other words, what they're saying is if somebody is already medicated because of hypertension and it brings their blood pressure below those norms, just the presence of medication for hypertension is a risk factor. So it doesn't discount that as a abnormality that contributes to metabolic syndrome. The third abnormality is a fasting plasma glucose over 100 milligrams per deciliter, or the diagnosis of diabetes mellitus type 2. Okay. So again, control with medications, you have that classification. That is a marker, or they diagnose that you are over that fasting level. Fourth on the list is an HDL value below 40 milligrams per deciliter for males and below 50 milligrams per deciliter for females. So we understand the value of physical activity and formalized exercise and its impact on HDL values. And so low HDL values are also indicative of a sedentary lifestyle. We're going to talk about physical activity as we move through this presentation. Research recently has surfaced stating that HDL, low HDLs have no value diagnostically, and that the ability to raise HDLs does not change your cardiovascular risk. And so that made headlines for a short period of time. One of the criticisms of some of the research that I read was none of the studies tried to raise HDL levels with exercise. Everything was medically or chemically. But then people latched onto that. HDLs don't make a difference. Okay. And fifth on the list is a fasting triglyceride of greater than 150 milligrams per deciliter. Why would triglyceride be in that equation? Why aren't we looking at LDLs? Anybody care to speculate? Okay. If you go back to your atherogenic lecture here, makeup. In each LDL particle, there's a major triglyceride component to it. Right? So in the breakdown of that LDL particle, you can also see what the amount of triglyceride is in the blood, which is indicative of how much LDL is in the blood. Plus, the triglyceride is also an excellent marker for not only elevated levels of cholesterol, but also for risk of diabetes. Okay, so it's a very good marker for both. Okay, some outlying markers for metabolic syndrome include a high C-reactive protein. C-reactive protein is an inflammatory marker. It's a very reliable marker for the development or the incidence of cardiovascular disease. So it's an inflammatory marker that raises the risk in the body. But most interestingly, with the high C-reactive protein, it's also indicative of non-alcoholic fatty liver disease. We're going to talk about metabolic syndrome being a disorder of energy metabolism in the body in a little bit. And when we talk about abnormalities in energy metabolism, and we're taking in too much food, which it provides us with the energy, where does that food go? And we're going to talk a little bit about storage system of fat and carbohydrates in the body and its impact on metabolic syndrome. Okay. Erectile dysfunction in men. Okay. An outlying marker for metabolic syndrome, accompanied by low free testosterone in the blood. So something is going on metabolically that is not allowing a man to perform and is lowering his testosterone. It could be a combination of an atherogenic situation in his body that doesn't preclude blood to get into that area and allow the person to perform. And part of it may also be, or a combination of both, low testosterone. What's inhibiting the testosterone other than the normal aging process? Okay. And for women, it is polycystic ovary syndrome. Okay, and that's usually associated with lower estrogen levels, but less so than what we would experience in what we observed in men. And going back to what I said earlier, just backtracking a little bit, when we talked about the original physician who kind of coined the phrase metabolic syndrome, he talked about the incidence of gout. Gout is an arthritic condition that is characterized by high uric acid. So high uric acid in the blood and incidence of gout, people who experience numerous bouts with gout are also outliers for metabolic syndrome. My opinion is we're using 5 right now as a standard, and we're using the marker of metabolic syndrome by classifying the person as having 3 of those markers. And we just went through a couple of other outliers there, and I think we're going to expand those markers in the coming years and get a little bit better with our blood work and start to include measures for C-reactive protein and uric acid, and not just the presence of symptoms and the presence of uric acid in the blood. Interestingly enough, and which kind of shocked me too, high uric acid and the propensity to experience a bout of gout is also directly correlated to high fructose intake. Okay? And how much fructose is in our soft drinks, including Gatorade? A lot. Okay? So So we're starting to notice a stronger correlation to the intake of fructose and the incidence of high uric acid and bouts of gout. Okay. So, going back to what I said prior, metabolic syndrome is considered a disorder of energy metabolism, and part of what we know about that energy metabolism is that we can also postulate that metabolic syndrome is a disorder of mitochondrial function. So, in other words, we're taking in food products or energy substrates, and we're using those substrates to produce energy, and we're asking the mitochondria in our body to process these energy substrates, but there's no pathway for immediate utilization, and that primary pathway is through physical activity. So there's a backlog of the carbohydrate production through the mitochondrial metabolism that backs up and shuts down the metabolism of the mitochondria in the body. Okay? So now, getting to a greater cellular level, we now have mitochondrial dysfunction as a result of taking in too many energy substrates. We have other disorders of the mitochondria that are much more devastating to the body, but as a result of our lifestyle and our energy substrate intake, we're imposing mitochondrial disorders. Okay. So, obviously, upper body obesity is indicative of visceral fat deposition. There is fat appearing in organs of the body that just shouldn't be there. So we can also make the assumption that there's a huge amount of upper body obesity, that there is some organ dysfunction related to the deposition of fat. And I mentioned prior that the liver, we have non-alcoholic fatty liver disease, which diminishes the function of the liver, and that is a vital organ, and you don't want to disrupt its natural function by any means. Okay? We've also seen fat deposition internally, where it changes the structure of the organs by creating pressure, and when you change the structure of an organ, you change the pressure, the function of the organ just by exerting pressure on it. So the presence of upper fat obesity or obesity in the upper body is a strong indicator for metabolic syndrome. Along with that presence of that upper body obesity, there is a strong release of cytokines into the body, which also produces an inflammatory response and raises the inflammation throughout the body, and that inflammatory response affects the arterial system of the body primarily. All right.
You think there is a strong release of what?
Cytokines.
Cytokines.
Okay. Okay, we're going to revisit that. When we get to risk factors, we're going to revisit that impact. Okay. Just some alarming statistics here: 34% of United States adults meet the criteria for metabolic syndrome. Okay. That is up 9% since 1999. Okay. And they estimate that there are possibly presently in our society another 25% do not know that they have metabolic syndrome. So they may have the markers for 3 out of the 5 of that constellation, and just don't have access to regular medical care that's going to give them that kind of feedback that they need treatment lifestyle education. So some of the risk factors for metabolic syndrome. Obviously, genetics is one of them. So the propensity to be overweight or to be obese is a genetic factor. The sensitivity to being diabetic is a genetic factor. We play around with that genetic moniker to the point where we almost use it as an excuse. In some of the research, some of the lifestyle diseases, whether our parents had it or not, it is estimated that about 17% of our lifestyle directly contributes to some of the morbidities that we develop as we age. So is it truly a purely genetic factor, or is it a propensity because of genetics and a lifestyle that we've learned? And I've heard some researchers refer to it as flipping the switch. So if you participate in a lifestyle and you have a propensity for a certain condition genetically, you can almost assure that somewhere in your DNA a switch is going to be flipped and it's going to turn on that morbidity that's going to affect your life. Okay, so that's number one. Number two, the lack of physical activity. A sedentary lifestyle, actually, the genetic part of it is first. Okay. So, when we did a survey of United States adults, we found, and when we made the criteria for formalized physical activity very simple. They came up with a definition of exercise, and they said that exercise has to be formalized physical activity. And it had to be 3 times a week for 20 minutes or more. 22% of the United States population met that criteria. Okay. So when we talk about the rise in the incidence of metabolic syndrome, only 22% of our population is participating on a regular basis in physical activity. It should not be a surprise that this is the constellation that we're putting together to diagnose and then treat people. Okay? So genetics is a strong indicator, and physical activity is a very strong indicator as well. An alarming statistic, if a person watches more than 4 hours of TV a day, they increase their risk for cardiovascular disease twofold. Now, think about what you do on Sunday when the NFL is going. So that's a lot of TV watching on Sundays. Age as a risk factor. 44% of the population, of the U.S. population over the age of 50 has metabolic syndrome or has been diagnosed with metabolic syndrome. 44% over the age of 50. And women make up a greater number of that percentage than men. Okay. The presence of type 2 diabetes at any age doubles your risk. The presence of type 2 diabetes doubles your risk for cardiovascular disease in the presence of metabolic syndrome. And a cardiovascular history. So you have diagnosis already. If you are diagnosed with cardiovascular disease before the age of 50, you have a 50% chance of experiencing another cardiovascular incident within 5 years.
So wouldn't that be related to genetics?
That part of it is genetics, how much of it is learned, how much of it is learned lifestyle, and you you have your mother and father's genes, and then you learn how to eat from them, and how to socially interact, and how to handle your anger, you know. So how much of that is nature? How much of it has been nurtured? Okay. So, okay. Some other strong indicators or risk factors: rheumatic arthritis, rheumatoid arthritis, psoriatic in nature, so psoriatic rheumatoid arthritis, or the presence of psoriasis. Why would that be a strong indicator, a strong marker? Because it's an inflammatory disease. Okay, so it has a very strong inflammatory presence in the body, and related to immune function. Okay. Obviously, chronic stress. Right? Stress is always low on the risk factor scale. My opinion is because we can't put a number to it. Right? It's hard to measure. And because it's hard to measure, it's difficult to treat. But here's what we know about chronic stress. People in chronic stress situations, they have a job that they're unhappy with. You're at school, you get papers back that you're not happy with. So you don't get them back all the time that you're not happy with. But chronic stress has a tendency to disrupt the hormonal balance of the body and create an inflammatory environment. So there's a strong interplay with the presence of stress and the function of your hypothalamus, your pituitary gland, and your adrenal glands. Okay? And the adrenaline that comes about as the result of chronic stress is chronic in nature to the point where it's a slow drip of adrenaline, and then the body has to work very hard to maintain homeostatic function. Okay? So if we think about the fight or flight mechanism, when we get an acute adrenal response or acute adrenaline response, right, we know what it produces in us, right? So it releases a lot of sugar in the body. Your acuity to all of your senses goes up. You want to stand there and fight, or you want to run, so you're mobilizing a lot of energy. Picture this as a kind of a slow cascade effect where it just happens all the time, just enough to be an irritant. And the reason it brings the pituitary and the hypothalamus in is because they communicate with each other to work toward metabolic balance in the body. But the adrenal glands seem to lead the way with that stressor response to the fact where it causes a disruption in normal function of the other two glands. Okay? So controlling your stress, easier said than done, but very valuable, very important. Okay, sugar. Let me just finish up with that stress response. With that stress response, there's also a release of cortisol in the body. That's a stress hormone. And that stress hormone leads to a catabolic state in the body. Right? So it's a breakdown of a lot of the proteins in the body. And the mobilization of some of those energy substrates to deposit fatty tissue, specifically increasing the adiposity of the upper body. Okay, so when we talk about upper body obesity, cortisol plays a big role. It's one of those stress hormones as well. Okay. Now let's revisit sugar. Sugar has a very interesting effect in the body, in addition to producing an inflammatory response in the body. But it also increases the cannabinoid system, the function of the cannabinoid system in our brains. Okay? So it's those feel-good hormones. So it actually feels good to take in sugar, right? So it becomes part of our reward system and almost like an addictive behavior, okay? When you take in a lot of sugar, it directly affects the corticolimbic system, and that is the system that gives us our executive reasoning to either accept something that is good for us or to discount something that is bad for us. Okay? So when you're constantly affecting that reward system and you create an addictive response, then your executive reasoning weakens and you no longer have the control to make the right decision, and that's where the impulse behaviors come in. So you have something going on, you know, you hear people say that, oh, I'm really stressed out and I just need a piece of chocolate.
Reese's.
Okay? And so you reach for that sugar-laden reward, and until you get it into your body, your executive reasoning is being compromised because you know that it's going to satisfy the behavior that you become accustomed to, and it's going to give you that physical relief. Then there may be some guilt afterward, you know, but you've pretty much trained your brain to respond very easily and override your ability to say, maybe this is a bad decision. So, and we talked about the fructose. Okay. So, how do we go about preventing metabolic syndrome? Okay. And in everything that I've researched, it begins with education. Make people aware. Okay. People have to be aware that this is a constellation of disorders that work together very devastatingly to a person's health. One of the things that I say to people is you don't want to join the healthcare system early in your life, because you will be part of that healthcare system for a long time if you do join that healthcare system. So once you're in that healthcare system, it's very difficult to get out. So part of that education is to get people to change their eating habits, increase their physical activity. The American College of Sports Medicine, about 4 years ago, started a campaign, Exercise is Medicine, and they wanted to get physicians on board where they would use the presence or absence of physical activity as one of the vital signs in every office visit for every patient. And some physicians are doing it, some physicians are not doing it. Education is still out there for our healthcare practitioners and for the general population of people as well. And then obviously getting people to get medical attention for their individual disorders. So you can't ignore any one of those constellations, right? You have to get medical help and treatment for any of those constellations. That's part of that metabolic syndrome. The first thing is reducing eating and weight management. So physicians are challenging their patients that before they begin medical treatment, meaning the administration of medications, that they should be challenging their patients with a 10% weight loss goal over the first 3 to 6 months of diagnosis. Okay, and that would be getting some training or some direction for some physical activity, and then meeting with a nutritionist. Obviously, physical activity, challenging the patient to become physically active. Initial goals are 150 minutes of formalized physical activity at least 3 days a week, and it can be in multiple bouts of exercise. So this is part of the Exercise is Medicine initiative. And we want people working up to 300 minutes of formalized physical activity 5 days a week or more. And what they put as a little caveat at the end there is most days of the week.
So these people are out of shape, and you know they're pretty much beginners to the gym when they work out. And you're saying 150 minutes per week. I understand based on the season guidelines, 1 or 2 week average, but they can't even do 50 minutes per week because of how heavy they are, how demotivated they are, and you know they're beginners. So like they get sore faster, you know, and they just don't want to do it. They don't want to do more of it. How do you push them?
With the initiation of any exercise program, there's always a foundational period. Okay? So that is the initial goal within the first 3 to 6 months. Right? So even if it's a 10-minute bout in the morning and a 10-minute bout in the afternoon, those are steps toward getting down toward that goal.
Okay. So the goal is 150. So work your
The
way up
initial
there.
goal is 150. The maintenance goal for weight loss is 300 minutes of physical activity a week, exercising most days of the week.
For us, the way I look at it, because I have a lot of diabetic clients who can't really do much, anything they do is going to be beneficial at that point. Going up the stairs to the second floor, walking, going to the food store, to the mall, walking anywhere. Anything they do at that point is going to benefit them. We're just there to help them through it. That's the way I can look at it. It may not be 150 minutes per week, but anything they do at that point is going to be beneficial to them.
Okay, moving on. Treating hypertension, and the first line of treatment is with an ACE inhibitor or a diuretic. We want to save the beta blockers for those with cardiovascular disease, so we want to be as gentle with the system as we possibly can. Obviously, managing triglycerides initially through dietary changes and exercise, but there's really no good medication that directly impacts lowering triglycerides. So we begin medication regimens with a statin, but we frown upon statins as a first line without attempting weight loss through dietary changes and physical activity, because statins also have an impact on the acquisition or the enhancement of diabetes type 2. Okay? So we got to be careful with our statin administration. And then obviously treating high blood sugars, diagnosing people with type 2 diabetes, and prescribing metformin, which increases their insulin sensitivity. Okay. So some programming guidelines. Exercise and physical activity is obviously number one. The FIT principle can be applied to people with metabolic syndrome, but obviously when you have a constellation of morbidities that affects their ability to exercise, considering each of the morbidities individually makes the exercise prescription very difficult. That's why we can generalize it that any formalized activity in multiple bouts, a minimum of 10 minutes, aspiring to that 150 minutes per week, and then eventually 300 minutes per week is a desired way to program exercise for your metabolic patients, metabolic syndrome patients. Okay. When we look at the intensity of the prescription, we want to look at approximately 40 to 60% of their heart rate reserve or their VO2 reserve. And the reason for that is because of other comorbidities associated with that constellation, it's going to be difficult to exercise test a lot of these people and get accurate information. So again, we're taking the intensity and we're generalizing it for our programming. And moving right along. Obviously, decreasing carbohydrate intake, targeting more specifically refined sugars and fructose, along with that physical activity. And some of the things that our medical community looks at when we take a look at metabolic syndrome as a single diagnosis. Not everybody in the medical community is on board because there is not enough support to say that the presence of obesity strongly correlates with the presence of cardiovascular disease. Okay? So there's inconclusive research that supports that. But the presence of cardiovascular disease may also have the presence of obesity. Okay? But we also know that people who are obese are more prone to diabetes, and that raises the risk for cardiovascular disease. It seems that the sensitivity to insulin is reduced because the presence of a lot of adipose tissue puts out a host of cytokines themselves that directly impacts the sensitivity and hormone balance in the body. So we know that we can look at the musculature of the body as an organ that puts out hormones, and we can also look at the fat in the body as an organ that puts out hormones. And they seem to be in direct contrast to each other, which further disrupts the metabolism of the body. Any questions?